Welcome to part 1 of our tuberculosis review for Step 2. In this video, we will master the pathophysiology, diagnosis, and treatment of active TB, including the right regimen, drug side effects, miliary TB, and special populations like pregnancy. Part 2 will cover latent TB and screening. Let's get started. Tuberculosis is caused by Mycobacterium tuberculosis, an acid-fast bacillus transmitted through aerosol droplet nuclei. It stains pink on the Ziehl-Neelsen stain because of its waxy mycolic acid cell wall. TB is the leading cause of death worldwide from a single infectious agent. The highest burden countries include India, China, Indonesia, the Philippines, Pakistan, Nigeria, and South Africa. Step 2 Pearl. Always ask about travel history or country of origin when TB is on your differential. Major risk factors for TB exposure include working in healthcare, migration from or travel to high-burden countries, close contact with an active TB patient, and crowded living conditions like homeless shelters or prisons. Immunocompromised states dramatically increase the risk of both infection and reactivation. These include HIV, TNF-alpha inhibitor therapy, chronic corticosteroid use, and organ or stem cell transplantation. Step 2 Pearl. HIV is the single strongest risk factor for TB reactivation. Every HIV patient should be screened for latent TB regardless of other risk factors. Primary TB occurs with the first exposure. The initial granuloma, called the Gone focus, forms in the middle or lower lung lobes where ventilation is highest. Together with the involved hilar lymph nodes and connecting lymphatics, it forms the Gone complex. In patients with a strong immune response, the granulomas undergo fibrosis and calcification, leading to latent TB. In patients with weak immunity, such as HIV or malnutrition, the infection progresses to active disease with lung destruction, bacteremia, or miliary spread. Step 2 Pearl. Most patients with primary TB are asymptomatic. A calcified Gone complex on chest X-ray simply indicates prior healed primary TB. Secondary TB, also called reactivation TB, happens when latent TB becomes active due to weakened immunity. Common triggers include HIV, TNF-alpha inhibitors, chronic steroids, malnutrition, and aging. Reactivation TB preferentially affects the upper lobes because of their higher oxygen tension, which favors mycobacterial growth. Because the patient was previously sensitized, the inflammatory response is much more vigorous, causing extensive tissue destruction, cavitation, and scarring. Step 2 Pearl. An upper lobe cavitary lesion combined with weight loss and night sweats is reactivation TB until proven otherwise. Clinical features of pulmonary TB fall into 2 categories. Systemic symptoms include low-grade fever, night sweats, unintentional weight loss, malaise, and decreased appetite. Pulmonary symptoms include chronic cough lasting more than 3 weeks, purulent sputum, hemoptysis, and pleuritic chest pain. Physical exam findings are nonspecific. Step 2 Pearl. Always consider TB in a young patient presenting with hemoptysis, or when a pneumonia fails to improve with standard antibiotics. The chronicity separates TB from typical bacterial pneumonia. For diagnosis, sputum samples are the most common specimens. Obtain at least 3 samples collected 8 to 24 hours apart, and include at least 1 early morning sample when the bacterial load is highest. 3 microbiological tests are used. The AFB smear using Ziehl-Neelsen stain is fast and cheap, but has low sensitivity and cannot distinguish M. tuberculosis from other mycobacteria. The nucleic acid amplification test, or NOT, has high sensitivity and specificity, gives rapid results, and detects drug resistance. Culture is the gold standard and provides drug susceptibility testing, but takes 2 to 6 weeks. Step 2 Pearl. Don't wait for cultures. If the AFB smear and NOT are positive and clinical suspicion is high, start empiric right therapy immediately. Chest imaging findings differ between primary and reactivation TB. Primary TB affects the middle or lower lobes. Classic findings include ill-defined consolidation, unilateral hilar lymphadenopathy, a Gone complex, and sometimes pleural effusion. Reactivation TB affects the upper lobes, showing fibrocaseous cavitary lesions, patchy consolidation, and calcifications. On CT, reactivation TB may show a tree and bud pattern, which represents bronchial spread. Step 2 Pearl. An upper lobe cavitary lesion is the hallmark of reactivation TB. A miliary pattern with tiny nodules throughout both lungs indicates hematogenous dissemination. Active TB is treated with the right regimen for a total of 6 months. The intensive phase lasts 2 months and uses all 4 drugs: rifampin, isoniazid, pyrazinamide, and ethambutol. The continuation phase lasts 4 months and uses only rifampin and isoniazid. Always add pyridoxine, or vitamin B6, alongside isoniazid to prevent peripheral neuropathy. Directly observed therapy, or DOT, is the standard of care to ensure compliance, where a healthcare worker watches the patient take each dose. Step 2 Pearl. Noncompliance is the main driver of drug-resistant TB, which is why DOT matters. Let's break down the side effects by drug. Isoniazid causes hepatotoxicity with elevated liver enzymes and peripheral neuropathy from vitamin B6 deficiency, which is why pyridoxine is always co-administered. It can also cause drug-induced lupus and sideroblastic anemia. Isoniazid is a CYP450 inhibitor, meaning it raises levels of other drugs. Rifampin causes orange discolorations of body fluids including urine, tears, and sweat. It can cause cholestatic hepatitis and thrombocytopenia. Rifampin is a potent CYP450 inducer, which reduces the efficacy of oral contraceptives, warfarin, and many antiretrovirals. Step 2 Pearl. In HIV patients on antiretrovirals, use rifabutin instead of rifampin to avoid these drug interactions. Pyrazinamide has the greatest hepatotoxicity potential of all the right drugs. It also causes hyperuricemia, which can trigger gout flares, along with arthralgia and photosensitivity. Ethambutol is the one ripe drug that is not hepatotoxic. Its hallmark side effect is optic neuritis, which presents as reversible red-green color blindness. It can also cause hyperuricemia. Step 2 Pearl. Always check baseline visual acuity and color vision before starting ethambutol, and monitor it throughout therapy. Monitor liver function tests monthly for all patients on RIPE, since 3 of the 4 drugs are hepatotoxic. Miliary TB results from hematogenous dissemination of M. tuberculosis, producing multiple small nodules throughout the lungs that resemble millet seeds on chest X-ray. It can affect almost any organ: lungs, spleen, liver, lymph nodes, meninges, vertebrae, or long bones. Pot disease is tuberculous spondylitis, which destroys vertebral bodies and produces a gibbous deformity. TB meningitis has a subacute course with basilar meningitis and cranial nerve involvement, especially the abducens nerve. CSF shows elevated protein, low glucose, lymphocytic pleocytosis, and a very high adenosine deaminase level. Step 2 Pearl. Fundoscopy revealing choroid tubercles is pathognomonic for miliary TB. Scrofula refers to TB cervical lymphadenitis. TB in pregnancy requires modified therapy. The standard first-line regimen lasts 9 months. The intensive phase uses rifampin, isoniazid, and ethambutol for 2 months. The continuation phase uses rifampin and isoniazid for 7 months. Pyridoxine is added throughout to prevent neuropathy. Several anti-TB drugs are contraindicated in pregnancy: streptomycin, amikacin, kanamycin, capreomycin, and all fluoroquinolones. Step 2 Pearl. Pyrazinamide is typically omitted in pregnancy in the U.S. due to limited safety data, although the WHO does allow it. Breastfeeding is actively encouraged while on standard therapy, since drug levels in breast milk are minimal and do not treat the infant. Let's wrap up part 1. For pathophysiology, primary TB affects the middle and lower lobes and forms the Ghon complex. Reactivation TB affects the upper lobes with cavitation. Miliary TB is hematogenous spread with tiny nodules. For diagnosis, AFB smear is fast but has low sensitivity, not as rapid, and detects resistance. Culture is the gold standard but takes weeks. The RIPE regimen is 6 months total. RIPE for 2 months, then rifampin and isoniazid for 4 more months, plus pyridoxine. Key drug side effects. Isoniazid causes neuropathy and hepatitis. Rifampin turns body fluids orange and induces CYP450. Pyrazinamide is the most hepatotoxic and causes hyperuricemia. Ethambutol causes optic neuritis. For extrapulmonary disease, miliary TB shows choroid tubercles. Pot disease affects the spine. TB meningitis shows elevated ADA in the CSF. Finally, the classic step 2 traps. An upper lobe cavity means reactivation TB. Always add B6 with isoniazid. In HIV, use rifabutin instead of rifampin. And in pregnancy, avoid pyrazinamide and fluoroquinolones. In part 2, we will cover latent TB, PPD versus IGRA screening, treatment regimens for LTBI, and the BCG vaccine. See you there.